Good morning. I'm Dr. BROJEN BARMAN, consultant urologist, Guwahati. Today I'm going to talk about the surgical anatomy of benign prostatic enlargement. The normal prostate lies below the base of the bladder, posterior to the symphysis pubis, anterior to the rectum, and superior to the urogenital diaphragm. The adult prostate is around the size of 5 into 4 into 3 centimeters and weigh about 20 grams. It progressively increases in its weight throughout the course of the person's age. Anatomical models of prostate glands, several models have been proposed, including the first Lausis-Lober model. Here he described the anterior, posterior, lateral, and middle lobes. The second being the Frank's concentric zone, based on whose work finally the McNeil's zonal model was described. It described three zones: transitional zone, central zone, and peripheral zone. Now, this is the most widely accepted model of the prostatic anatomy. Landmarks of the prostate, through the prostate, the prostatic urethra courses. It starts from the internal urethral opening and ends at the sphincter urethral muscle level, the urogenital diaphragm. This is what you see when you do a cystoscopic examination. This most prominent protuberance is the verumentinum. And the verumentinum, there's the opening of the prostatic utricle. By the side of utricle, there are two ejaculatory ducts. This sinuses by the side of the verumentinums have the openings of several prostatic ducts. This is a retrograde ureterogram of a normal patient, and these are the landmarks. This is the level of the verumentinum, and herein lies the membranous urethra, and this is the level of the external sphincter. Just over the verumentinum in this part, these are the lobes of the prostate. The prevalence of histological BPH increases with ages across all population. Not only the histological grade, the weight of the prostate also progressively increases after the age of 30, and it remains stable for a while, for 30 to 50 years, slow increase in the weight. However, after the age of 50 years, there is sudden increase in the prostatic weight. When you talk about the anatomy of benign prostatic enlargement or hyperplasia, this is the classical image that you remember. The bladder is hypertrophied, trabeculated. This is the prostate grossly enlarged. There is a median lobe as well as, and probably there is the presence of bilateral hydroureteronephrosis, and the creatinine may be raised. These are the classical specimen of enlarged prostate. The prostatic urethra is tortuous, dilated. These are the nodules of enlarged prostate. In this image, you can see there is asymmetrical hypertrophy of the prostate, the right lobe being larger than the left lobe. This is a specimen of enlarged prostate, and this is a region of a prostatic infarct. In this specimen, you can see the part of a median lobe or the medial lobe enlarging into the prostate. This is the classical uvula or the medial lobe. The prostate comes in various sizes, shapes, and weight. For a 20 to 50 gram prostate, it is usually symmetrically enlarged. However, there may be long lobes, short lobe, globular lobes. There may be asymmetrical glandular hypertrophy. In this image, the right lobe is larger than the left one, or some patient may come with a large median lobe. This is the classical description of the lobes of prostate. This is the anterior lobe or the anterior fibromuscular stroma. This is the posterior lobe. It is very important in relation to TURP. A large amount of prostatic tissue is left behind when we do TURP. The left tissue is mostly the posterior lobe. These are the lateral lobes, the most prominent one, and this is the superior lobe or the median or the medial lobe. According to McNeil's zonal anatomy, the transitional zone will give rise to the median lobe. The central zone and the peripheral zones will give rise to posterior and the lateral lobes. The anterior fibromuscular will give rise to the anterior lobes. Let us talk about the capsule of the prostate. Capsule of the prostate is in contrast with the capsule of the thyroid gland. Here you see the venous plexus lying between the true and the false capsule. However, in case of thyroid, the venous plexus are inside the capsule of the gland. This is the capsule of the prostate, much more better seen when you do a HOLEP procedure, when you elevate the lobes of the prostate. However, the capsule of the prostate is a very ill-defined structure, varying from 0.5 to 3 mm in thickness. Outer to this, there is a fibromuscular tissue, fatty tissues, and inside this is the glandular element of the prostate. These are the smooth muscles of the capsule of the prostate. Arterial bleeders. The prostate is supplied by branches of the inferior vesical artery, middle rectal, or internal pudendal artery. This is the branch from the inferior vesical artery. It courses, giving rise to the urethral group of arteries, and the second group of arteries are the capsular branches. One of the significant annoying bleeders when you do TURP is the bleeding near verumontanum. Herein you find there are minor branches from the middle hemorrhoidal and pudendal arteries. These are two major arteries that we are scared of. Bleeding at the 5 or 7 o'clock, maybe because of the Badenoch artery. This one, Badenoch artery, 5 and 7 o'clock, coagulated here. And these are the flux artery at 2 or the 10 o'clock position that you encounter during TURP procedures. However, there may be wide variation in their presence and location. The internal iliac artery and its branches have been classified according to Yamaki. Because of the progress in the angioembolization involving the prostatic artery, we know much more about the anatomy of the prostatic artery now. This is the angiographic classification of prostatic artery. They have been divided into type 1 to type 4. Venous bleeders, if we're inside the capsule of the prostate, we will not encounter them. Or if there's a deep cut, of course, there can be a significant and a troublesome venous bleeding. This is the deep dorsal vein of the penis, divides into the superficial branch. This is the deep dorsal branch here. And these are the lateral venous plexus. They all drain into the hypogastric vein and finally to the internal iliac vein. There is a network of intraprostatic lymphatics that drains principally into the obturator and then to the internal iliac lymph nodes. A minor amount of drainage may occur through the presacral and external iliac nodes. An uncommon site of flow is through the periprostatic and the periseminal vesical lymph nodes present in about 4% of the patient. This tends to be small lymph nodes, average around 2 mm in the great dimension. Node supply was supplied by a rich network of sympathetic and parasympathetic innervation. The anatomy of the node supply is important when you are contemplating bladder neck incision or incision of the prostate involving smaller prostate. This is the view of the external sphincter just below the verumontanum. This is the cystoscopic view of the external sphincter. The external sphincter has several dispositions. It's a very simple depiction of what happens to the external sphincter in case it is enlarged. This is the normal position. When the lobes are too much enlarged, they are more horizontal, thin out, spread out, more likely to get injured during any procedure involving the prostate glands. A significant amount of prostatic tissue is left behind below the verumontanum. Verumontanum is taken as the landmark. The length of the prostate that varies can be from 8 to 44%, and the weight of the prostate that remains below and behind the verumontanum can vary from 2 to just slightly below 40%. So how much prostate is below the veru? Sometimes a significant amount of prostate can be left behind. How much veru can be resected? It is better not to resect a veru being a very important landmark during the procedure of involving HOLEP or any laser procedure or TURP. However, part of the veru may be resected, maybe about half of it, without compromising the integrity of the sphincter. Does intake veru equals to intake external sphincter? No, it does not. This is the anatomy after TURP or HOLEP procedure. This is the view that you should get. This is the lonely veru appearance. The bladder neck should be easily visualized from the level of the veru. There is some deep deep cut or perforation involving the capsule of the prostate. This is an image showing a venous bleeder. So either we do an open prostate or a TURP procedure or a HOLEP or any other laser procedure, intricate understanding of the prostatic anatomy in relation to enlarged prostate is very important. Thank you.